Welcome to Cross-Examination, a series that looks closely at how a single trial is designed, reported, and interpreted, and at what can and cannot be concluded from it. Today's paper is a randomized controlled trial of segment 4B5 versus wedge resection for gallbladder cancer, published in Annals of Surgery in 2026 from the Rajiv Gandhi Cancer Institute in Delhi, a high-volume center in North India's gallbladder cancer belt. It is the first randomized trial to compare these two operations from an experienced hepatobiliary group that had previously described its own 4B5 technique. Consider the conclusion as stated. The authors report that anatomic 4B5 resection and non-anatomical wedge resection had similar morbidity, disease-free and overall survival, and that the type of liver resection did not affect long-term oncological outcomes. What follows examines what the data support for that conclusion and where interpretation is best kept cautious, using CONSORT and standard trial appraisal principles as the reference. The design. A single-center phase 3 open-label parallel group randomized trial enrolling from 2014 to 2023. Patients with resectable gallbladder cancer were randomized intraoperatively 1:1 to segment 4BR5 or wedge resection during radical cholecystectomy. The primary outcome was overall survival. Secondary outcomes were surgical. After excluding benign histology on final pathology, 163 patients were analyzed, 83 and 80. Median follow-up was 27 months. The results. No comparison reached statistical significance. 3-year overall survival was 64% for 4B5 and 79% for wedge. The hazard ratio was 0.64, 95% confidence interval 0.36 to 1.14, p equals 0.12. Disease-free survival was similar between the arms. Segment 4B5 was associated with a longer operating time, about 31 minutes, and greater blood loss with no difference in morbidity, mortality, or R0 resection rate. It helps to place the trial in context. The earlier comparisons of these two operations are retrospective, matched cohorts, case control series, and meta-analyses of retrospective data. Across them, anatomic 4B5 has generally not shown a clear survival advantage over a margin-negative wedge, and several report greater morbidity with the anatomic resection. This trial is the first randomized comparison, and its direction is consistent with that body of evidence rather than contradicting it. A randomized result concordant with prior data carries more weight than an isolated finding. Read against the CONSORT checklist, several items are well met. It is a randomized 1:1 comparison. Eligibility and both operations are described in detail, and adjuvant therapy was standardized across arms, an advantage over the retrospective literature where adjuvant treatment often varied. Two items are worth noting for interpretation. The primary endpoint is overall survival, assessed at a median follow-up of 27 months, and the sample size assumed a 20% improvement in 3-year survival with the significance threshold set at 0.10. On randomization and reporting. Allocation used simple manual randomization with opaque sealed envelopes. The concealment procedure is described briefly. The trial is open label, which for an overall survival endpoint is of limited concern since death is an objective outcome. The analysis set is 83 and 80 after excluding benign histology following randomization, and the registry identifier is dated 2018 while enrollment began in 2014. Each of these is worth examining for what it means for interpretation. There are two accurate ways to describe the same result. As reported, the trial shows no significant difference between the operations. On closer reading, it is a superiority comparison that did not reach significance, with a numerical survival difference and a relatively short follow-up. Both descriptions are correct. The points that follow examine which conclusions each one supports. The first and most important point of interpretation is the distinction between a superiority and an equivalence question. The trial was designed and powered to detect 4b5 as superior, and the result was non-significant. By standard convention, a non-significant superiority trial establishes that superiority was not demonstrated. On its own, it does not establish that the two operations are equivalent. Demonstrating equivalence calls for a different design, a pre-specified margin defining the largest survival difference considered clinically acceptable, as set out in the CONSORT extension for non-inferiority and equivalence trials and summarized by Altman and Bland. Absence of evidence is not evidence of absence. The confidence interval illustrates the point. A hazard ratio of 0.64 with limits from 0.36 to 1.14 remains compatible with a range of outcomes, from a meaningful difference favoring wedge to a smaller difference favoring 4b5. The supported reading is that a difference was not detected, rather than that the operations are the same. The second point concerns follow-up. The primary endpoint is overall survival, and median follow-up is 27 months, with median survival not yet reached. In gallbladder cancer, deaths and recurrences continue to accrue beyond 2 years, so 3 and 5-year estimates at this follow-up rest on smaller numbers at risk and are correspondingly less stable. The implication is that the survival comparison is best regarded as an interim analysis. Any late separation of the curves, the interval in which an anatomic resection might plausibly affect micrometastatic disease, would not yet be apparent. The third point concerns statistical power. The sample size assumed a 20% absolute improvement in 3-year survival, a large assumed effect, with a threshold set at 0.10. A trial sized on a large assumed effect is well placed to detect a large difference, but has limited power for smaller differences that may still be clinically relevant. Here, the observed difference did not reach significance and the confidence interval is wide, so the result is consistent with imprecision, a difference not excluded in either direction, rather than with demonstrated equivalence. The relatively lenient threshold is also worth keeping in mind when interpreting the secondary surgical comparisons that did reach significance. The fourth point concerns registration. Enrollment began in 2014, while the registry identifier is dated 2018, and a full protocol is not linked. Prospective registration allows the pre-specified primary outcome and analysis plan to be verified against the final report. When registration follows enrollment, that external verification is not available. This does not indicate that anything was changed. It removes one external check and is noted as a limitation for interpretation consistent with CONSORT item 23. The fifth point concerns generalizability. All procedures were performed at a single center by an experienced hepatobiliary surgeon in a single population. That consistency of technique strengthens the internal comparison. It also means the results reflect a specialized setting. In particular, the finding of comparable morbidity between the two operations may reflect that expertise. Some earlier series in other settings have reported greater morbidity with the anatomic resection. Extending the safety comparison beyond similar centers is therefore best done with caution. A sixth, more minor point concerns the analysis population. 17 patients, 7 and 10, were excluded after randomization because final histology was benign, leaving 83 and 80. Strictly, this departs from an intention to treat analysis. The exclusions are reasonable. Benign disease is outside the trial scope. The numbers are similar between arms, and a 15% attrition was anticipated in the sample size calculation. It is noted for completeness rather than as a material concern. Summarizing the quantitative picture, the 3-year survival difference is 15 percentage points, numerically favoring wedge. The confidence interval spans a meaningful difference in either direction. The comparison is non-significant at the stated threshold. Follow-up is short relative to the endpoint and the trial was powered for a large effect. Segment 4B5 was associated with additional operating time and blood loss. Taken together, the data are consistent with a difference that was not detected alongside prior retrospective evidence that has not shown a survival advantage for the anatomic resection. On the ROB2 framework, the measurement of the outcome is low concern since survival is objective. The randomization process and missing outcome data are rated some concerns, and selection of the reported result is rated higher concern given the registration timing and the absence of a linked protocol. For the equivalence interpretation specifically, the overall rating reflects the distinction between the superiority design and the equivalence conclusion, not the surgical conduct which is described consistently. Two questions follow from all this. First, what does the trial support for current practice? Considered alongside the prior evidence, it does not show a survival advantage for anatomic 4B5 over a margin negative wedge, and it is associated with additional operating time and blood loss, consistent with the existing retrospective literature. It is also relevant that this result comes from a group experienced in and previously supportive of the 4B5 technique. A reasonable interpretation is that for a patient in whom a margin negative wedge is achievable, extending the liver resection is not required on oncological grounds by the current evidence. The data do not establish equivalence that would require the design discussed earlier. The trial is best read as adding randomized support to the existing evidence rather than as settling the question on its own. Second, what would a future study need to answer the question more definitively? A non-inferiority design with a pre-specified, clinically justified survival margin, analyzed by both intention to treat and per protocol. Sizing for a realistic difference at a conventional threshold, which would require a multi-center trial to reach the numbers. Follow-up long enough for the survival endpoint to mature. Prospective registration with an accessible protocol. And stratification by T-stage, since any effect of anatomic resection may be most relevant in deeper tumors. The general teaching point extends well beyond this paper. A non-significant result is not the same as equivalence. Three questions distinguish them. Was the study designed and powered to demonstrate equivalence with a margin? Is the primary endpoint mature? And does the confidence interval still include a difference that would matter clinically? For this trial, those considerations indicate that the result is best described as a difference not demonstrated, consistent with the existing evidence that the anatomic resection does not confer a survival advantage. A study can be a valuable contribution while its strongest stated conclusion is read with appropriate caution. That concludes this appraisal. Thank you for watching Cross Examination. I am Dr. Gautam Krishnamurthy. Until the next case.